Bismillahirrahmanirrahim. The topic of this class is general management of diarrhea and treatment of inflammatory bowel disease. The lecture objectives include review of main points in the management of diarrhea first, then classification of antidiarrheal drugs and their actions in brief, followed by introduction to IBD, rationale of its treatment, classification of drugs used to treat inflammatory bowel disease, and in the end pharmacology of different drugs used in the treatment of IBD. Now in the start, the rational management of diarrhea depends on correcting the underlying cause. The main therapeutic measures are three. Number one, treatment of fluid loss, which is known as rehydration, then maintenance of nutrition, and then drug therapy according to the cause of the diarrhea. Rehydration, which is the main risk of acute diarrhea, is the dehydration. And the common therapies are aimed at reducing fecal water loss and replacing lost fluid and electrolytes. In majority of the cases, rehydration is the only measure needed, and the cause may be virus, which is self-limiting. In many cases, rehydration can be done orally or intravenously. Oral rehydration, particular solution ORS, oral rehydration solution, which is recommended by WHO, is used for rehydration. It should be isotonic, should contain glucose in somewhat higher ratio than sodium chloride, and enough potassium and bicarbonate or citrate be provided to recover losses in the due to the loose motions. The maintenance of nutrition is another important area in the treatment of diarrhea. Patients of diarrhea should not be starved. Fasting decreases breast butter disaccharide enzyme and reduces absorption of salt, water, and nutrients. It may also lead to malnutrition if diarrhea is prolonged or if it is recurrent. The feeding during diarrhea has shown to increase intestinal digestive enzymes and cell proliferation and mucosa. Simple foods like breast milk or half-strength buffalo milk or boiled potato, rice, chicken soup, banana, and sagu should be given as soon as patient can take. Now the classification of antidiarrheal drugs, the opioid agonists like loperamide and diphenoxylate are used. Second group is colloidal bismuth compounds like bismuth subsalicylate and bismuth subcitrate. Then adsorbents like kaolin and pectin. Then bile salt binding resins, and finally the octreotide, which is the somatostatin analog. The opioid agonists, loperamide and diphenoxylate, inhibit the cholinergic transmission in the submucosal and mesenteric plexus in the GIT, and they decrease the GI motility and increase the transit time. The colloidal bismuth compounds make a protective layer over the mucosa. They are used in the dry diarrhea, particularly in the traveler's diarrhea. The kaolin and pectin are adsorbents. They adsorb toxins, bacteria, and fluids and other things, and they decrease the movement of the intestine. The bile salt binding resins, cholestyramine and cholestyramine, are effective to treat the diarrhea due to the bile salt excess, which may be due to the malabsorption of the bile salts. The octreotide is the somatostatin analog. It decreases the intestinal movements and secretion as well, along with the other actions. The symptomatic relief to the diarrhea and the cramps may be provided by the antimuscarinic agents. These are smooth muscle relaxants that decrease intestinal motility and gastric secretions. They relieve cramps in stomach and intestine and in bladder and gallbladder. The preparations available of antimuscarinics are atropine, hyoscine, and propenthyline. Now coming to the main topic of this class, the treatment of inflammatory bowel disease. This inflammatory bowel disease, abbreviated as IBD, is a group of inflammatory conditions of the rectum, colon, and small intestine. Two types of IBD are identified as Crohn's disease and ulcerative colitis. Crohn's disease affects the small intestine and large intestine, as well as the mouth, esophagus, stomach, and anus, while ulcerative colitis mainly affects the colon and rectum. The inflammation is the main lesion of this disease. Symptoms of IBD, inflammatory bowel disease, may include abdominal pain, mainly pelvic area, the diarrhea, rectal bleeding, cramps, or muscle spasms in the region of the pelvic and pelvis, and weight loss. Anemia is also one of the most prevalent extraintestinal complications of IBD. The cause of IBD, exact cause of inflammatory bowel disease is not known, but the disease has some autoimmune and genetic basis of pathogenesis. Use of antibiotics before the diagnosis of IBD due to diarrhea damages normal intestinal flora, and these damages to the intestinal flora induce an inappropriate, uncontrolled immune response that may also result in the damage to the intestinal epithelium. And now these damages, the breaches in this intestinal epithelium, allow further infiltration of microflora that in turn elicit further immune response. So finally, the inflammation will prevail in this condition. Management, as the etiology and pathogenesis of inflammatory bowel disease are unknown, so the pharmacological treatment of inflammatory bowel disorder is done with the drugs of different therapeutic classes possessing anti-inflammatory action. As it is the inflammatory bowel disease, it means that the symptomatic treatment, because the cause is not known. In most cases, mild signs and symptoms of IBD can be controlled by changes in the diet and in the lifestyle. Now, the dietary changes, it is known that gluten sensitivity is common in IBD. It is associated with having flare-ups in the disease. Some people with IBD have reported improvement in symptoms when they stopped eating gluten. Gluten is found in wheat, barley, rye, and others. Secondly, a diet high in protein, particularly animal protein, may be associated with increased risk of inflammatory bowel disease and its relapse. And stopping this high protein intake has been associated with the decreased risk of worsening of IBD and its relapse. Now, the treatment mentioning the first type, ulcerative colitis. It is the type of IBD, so it is inflammatory condition involving mostly rectum, sigmoid colon, and in few cases whole colon is involved with infiltration of chronic inflammatory cells like macrophages, lymphocytes, and polymorphs. This disease usually starts in young adults and reaches its peak in 6th or 7th decades of life. Clinical manifestations are rectal bleeding, mucus discharge, tenesmus, means burning sensation while defecation, and diarrhea. The drug therapy of this colitis is divided into two components: the treatment of acute condition and the prevention of relapse or maintenance of remission or recovery. The acute colitis is treated mainly with a group of drugs known as corticosteroids or glucocorticoids. These glucocorticoids are beneficial in the treatment of acute colitis because they have got the prominent anti-inflammatory action. Locally applied glucocorticoids like prednisolone and hydrocortisone in the form of enemas or foams, suppositories are preferred to avoid systemic side effects of glucocorticoids and ensure effective delivery at the site of inflammation, because the inflammation site is rectum or colon, which are distal parts of the intestine. Systemic glucocorticoids can also be used in patients who cannot retain topical forms of glucocorticoids or who have unavailability or are reluctant to those. The patients refractory to corticosteroid therapy or who relapse frequently should be considered to be treated with immunosuppressive drug therapy as well. For example, with azathioprine or 6-mercaptopurine or methotrexate or other alternates. These agents are immunosuppressive agents. They appear to be effective in such patients in the relief of symptoms of inflammatory bowel disease. The other class of the drugs, aminosalicylates. These are the drugs which deliver 5-aminosalicylic acid locally in the colon. These are effective and preferred to prevent relapse of ulcerative colitis or Crohn's disease. Important drugs of this class that delivers 5-aminosalicylic acid are azo compounds and number 2 mesalamine compounds. Azo compounds include sulfasalazine, orsalazine, and belsalazine, belsalazide. And mesalamine compounds include pentasa, esacol, epriso, and lialda. The enemas and suppositories are also formulated to deliver 5-aminosalicylic acid in high concentrations to the rectum and sigmoid colon. This mechanism of this group of the drugs. The 5-aminosalicylic acid which is delivered in the blood, it blocks cyclooxygenase pathway and inhibits prostaglandin synthesis, so it decreases inflammation. It is thought that 5-aminosalicylic acid modulates inflammatory mediators derived from both cyclooxygenase as well as lipoxygenase pathways. 5-aminosalicylic acid also inhibits the activity of nuclear factor kappa B, NFKB, an important transcription factor for pro-inflammatory cytokines, and its inhibition gives the benefit against inflammation. 5 ASA, amino-salicylic acid, may also inhibit cellular functions of natural killer cells, mucosal lymphocytes and macrophages, and may also act as free radical scavenger. In these ways, the inflammation is remarkably suppressed. 5. ASA may also inhibit cellular functions of natural killer cells, mucosal lymphocytes and macrophages. These clinical uses of aminosalicylates. These drugs, aminosalicylic acid delivering drugs, are considered to be the first line agents for the treatment of mild to moderate active ulcerative colitis. Although their efficacy in Crohn's disease is not proven, but many clinicians use 5-ASA agents as first line therapy for mild to moderate Crohn's disease, which has involved the colon or distal ileum. Clinical uses of aminosalicylates. The patients of ulcerative colitis or Crohn's disease having lesions of rectum, means proctitis, or distal colon, means proctosigmoiditis, can be effectively treated with 5-aminosalicylic acids suppositories or enemas. In patients with inflammatory bowel disease whose lesion extends to the proximal colon, both of these drug classes, azo compounds and mesalamine preparations, are useful. Their adverse effects, aminosalicylates except sulfasalazine, all are well tolerated, having minimum side effects. The hypersensitivity reactions may occur rarely with all aminosalicylates but are more common with sulfasalazine. Salazine may stimulate a secretory diarrhea in 10% of the patients, and its cause is not well known. The renal tubular damage and rarely interstitial nephritis is also reported in some patients receiving high doses of aminosalicylates. Now, the sulfasalazine, one of the aminosalicylates, is a combination of 5-aminosalicylic acid and sulfapyridine bound by loose azo bond. The sulfasalazine has low solubility. It is poorly absorbed from the GIT in distal ileum and colon. It splits into 5-aminosalicylic acid and sulfapyridine by bacterial flora. The 5-ASA exerts local anti-inflammatory effect in the colon and distal ileum by inhibiting prostaglandin synthesis and by inhibiting migration of inflammatory cells in the intestinal wall. Sulfasalazine also decreases mucosal secretions and produces relief in ulcerative colitis and other inflammatory bowel diseases. Sulfapyridine, its other metabolite, serves to carry 5-ASA to the colon without being absorbed proximally in the small intestine. Sulfasalazine clinical uses. Given during the exacerbation, sulfasalazine reduces the number of stools, abdominal cramps, and fever. Sulfapyridine may be absorbed from the colon and produces adverse effects like skin rashes, fever, joint pain, hemolysis, nausea, vomiting, headache, and male infertility. Then the second class of the drugs, mesalamine compounds, pentasa, esacol, eprisol, and lialda are the official names of 5-aminosalicylates delivering mesalamine compounds. Pentasa reduces 5-ASA throughout the small intestine. Pentasa release 5-aminosalicylate in the whole of the intestine. Isacol and iprazole contain aminosalicylate coated in a pH sensitive resin. This resin is dissolved at pH ranging 6 to 7, which is the pH of distal ileum and proximal colon. So it is dissolved in distal portion of the intestine, and the drug is absorbed over there. A pH dependent resin is also used in Lialda that enables it to slow release of mesalamine throughout the colon. The adverse effects of these compounds: the mesalazine is better tolerated and produces lesser side effects than sulfasalazine. Mesalazine is also the name of mesalamine. Nausea, vomiting, abdominal discomfort, and headache are the side effects observed with mesalamine preparations. It has nephrotoxic potential and it is contraindicated in the renal disease. The next class of the drugs, the immunosuppressant drugs, purine analogs, the azathioprine and 6-mercaptopurine. These purine antimetabolites have immunosuppressant properties. After absorption, azathioprine is rapidly converted by a non-enzymatic process to 6-mercaptopurine. This 6-mercaptopurine subsequently undergoes biotransformation, which produces active metabolite thioguanine nucleotides. The azathioprine and mercaptopurine have a serum half-life of less than 2 hours. However, the active 6-thioguanine nucleotides have a prolonged half-life of many days. So it takes 17 weeks for onset of therapeutic benefit from oral azathioprine or oral mercaptopurine given in patients with inflammatory bowel disease. Clinical uses of these azathioprine and mercaptopurine are effective to achieve and maintain the remission. Remission means recovery from ulcerative colitis and Crohn's disease. These agents help to achieve recovery in 50 to 60% of the patients in 3 to 6 months of the treatment, and to maintain recovery in up to 80% of the IBD patients. Addition of purine analogs to active IBD patients which are kept on long-term glucocorticoid therapy allows the dose reduction or elimination of steroids in the majority. Means the combination therapy will provide the benefit of reducing the dose of both the glucocorticoids as well as these immunosuppressants. So by reducing the doses, we will face lesser side effects. The adverse effects of these immunosuppressants, purine analogs, treatment with these agents can cause the side effects like bone marrow suppression, which can lead to leukopenia, macrocytosis, anemia or thrombocytopenia, and the general side effects like nausea, vomiting, and myalgia. The hematologic complications occur less frequently on the low doses of these drugs. The drug-induced pancreatitis occurs as side effect in 3 to 15% of the patients, but it resolves on the withdrawal of the drug. When the drug is stopped, the pancreatitis becomes corrected. The hypersensitivity reactions to azathioprine or mercaptopurine occur in 5% of the patients, and these drugs cross the placenta, so these should not be given in the pregnant ladies. The next drug, methotrexate, It is also given as to suppress the immunosuppression. Methotrexate, which is an anti-metabolite, it is effective in a number of chronic inflammatory diseases, including Crohn's disease, along with the rheumatoid arthritis and cancer. It may be given orally, subcutaneously, or intramuscularly. This methotrexate inhibits cellular proliferation when used in high doses for chemotherapy. Means methotrexate damages the normal cells. However, when used in the low doses, means in between 12 to 25 milligram or 15 to 25 milligram once a week to treat inflammatory bowel disease, and the anti-proliferative effects may not be observed. Mechanism of action of methotrexate is inhibition of dihydrofolate reductase enzyme, which is important in the production of thymidine and purines. The methotrexate may interfere with the inflammatory actions of interleukin-1 as well. It may also stimulate increased release of adenosine, which is an endogenous anti-inflammatory attacoid. The methotrexate may also stimulate apoptosis. Apoptosis means programmed regular death and death of activated T lymphocytes. Clinical uses of methotrexate. Definitely, we are here considering the drugs used for the treatment of inflammatory bowel disease. This drug methotrexate is used to induce and maintain the recovery in patients with Crohn's disease. Its efficacy in ulcerative colitis is uncertain. To achieve recovery, the patients are treated with 15 to 25 milligram of methotrexate once a week by subcutaneous injection. After treatment of a satisfactory response in 8 to 12 weeks, means 2 to 3 months, the dose is reduced to 15 milligram per week. The adverse effects of methotrexate: in higher doses, it may cause bone marrow suppression, megaloblastic anemia, alopecia, and mucositis. In lower doses, usually it does not cause such adverse effects. Folate supplementation also reduces the risk of these events. The hepatic damage is rarely noted with low dose given to the patients of IBD and rheumatoid arthritis. The renal insufficiency may increase the risk of hepatic toxicity. Now another class of the drugs to treat the IBD, anti-tumor necrosis factor therapy, anti-TNF therapy. One of the main pro-inflammatory cytokines which are active in inflammatory bowel disease and in other inflammatory conditions is the tumor necrosis factor TNF. This TNF is produced by the innate immune system, for example, dendritic cells, macrophages, and the adaptive immune system like helper T cells type 1 and non-immune cells like fibroblasts, smooth muscle cells. This TNF exerts many pro-inflammatory actions which lead to the inflammation in IBD, especially Crohn's disease. Now the biological activity of TNF, its mechanism of action. The activity is mediated by binding to TNF receptors that are present on some cells, especially helper T cells type 1, innate immune cells, and fibroblasts. TNF actions include release of pro-inflammatory cytokines from macrophages, T cell activation and proliferation, fibroblast collagen production, the upregulation of endothelial adhesion molecules, which are responsible for new leukocyte migrations, and many other actions, pro-inflammatory actions. Now the drugs which are active against TNF, which are used in the treatment of inflammatory bowel disease. We have developed 3 monoclonal antibodies to human TNF. These 3 antibodies are approved for the treatment of inflammatory bowel disease. These are named as infliximab, adalimumab, and certolizumab. The first two, infliximab and adalimumab, are antibodies of IgG1 subclass. And the third, certolizumab, is a recombinant antibody. It contains a Fab fragment that is conjugated to polyethylene glycol but lacks an Fc portion. Mechanism of action of these antibodies: all these 3 agents bind to TNF with high affinity. They prevent the cytokine from binding to its receptors, means TNF receptors. And binding of all 3 antibodies to membrane bound TNF also causes reverse signaling that suppress cytokine release as well. After binding of infliximab and adalimumab to membrane-bound TNF, the Fc portion of the human IgG1 region promotes antibody-mediated apoptosis and complement activation and cellular cytotoxicity of activated T lymphocytes and macrophages. These are all anti-inflammatory actions. The clinical uses of these antibodies: all of these are approved for acute and chronic treatment of moderate to severe Crohn's disease. The infliximab is also approved for acute and chronic treatment of moderate to severe ulcerative colitis as well. Many other immune-mediated disorders are the indications of these anti-TNF antibodies. The infliximab is administered as an IV infusion at therapeutic doses of 5 to 10 mg per kg of body weight. The adalimumab and certolizumab are administered by subcutaneous injections. The adverse effects of these anti-TNF drugs: the serious side effects occur in up to 6% of the patients with anti-TNF therapy. Important is infection. Infections happen due to the suppression of the helper T cells inflammatory response. Serious infections may include bacterial sepsis, tuberculosis, invasive fungal organisms, reactivation of hepatitis B, listeriosis, and other opportunistic infections. The reactivation of latent tuberculosis with dissemination is also noted. Less serious infections may include upper respiratory tract infections like sinusitis, bronchitis, and pneumonia and cellulitis. Now, this is the last class of drugs used to treat the inflammatory bowel disease: anti-integrin therapy. Because this drug, natalizumab, works for the inhibition of the integrin. This natalizumab is developed as immunosuppressant. It is a humanized IgG4 monoclonal antibody which is targeted against alpha-4 subunit of integrins. And what are integrins? These are a family of adhesion molecules on the surface of leukocytes that may interact with another class of adhesion molecules on the surface of vascular endothelium. Those adhesion molecules on endothelium, vascular endothelium, are known as selectants. And this adhesion, this interaction with the selectants allows circulating leukocytes to adhere to vascular endothelium and subsequently move through the vessel wall into the tissue. Means the leukocytes may leak from the vessels to the tissues. Now the actions of this drug natalizumab, IgG4 monoclonal antibody natalizumab binds to alpha-4 subunit of antigens and thereby blocks several antigens on circulating inflammatory cells. In this way, it prevents binding of antigens to the vascular adhesion molecules and inhibits their subsequent migration of leukocytes into the surrounding tissues. Clinical use of the natalizumab, it is approved for the patients with moderate to severe Crohn's disease who have failed other therapies through a carefully restricted program. The approved dose of natalizumab is 300 mg every 4 weeks given IV by infusion, with the condition that patients should not be kept on any other immunosuppressant drug. The adverse effects of natalizumab. One serious adverse effect was observed in a clinical trial that natalizumab developed progressive multifocal leukoencephalopathy in 3 patients. Of the trial participants were 1300, but 3 of those developed progressive multifocal leukoencephalopathy due to reactivation of a human polyoma virus, JC virus, which is present in latent form in over 80% of the adult population. Besides this adverse effect, other adverse effects include acute infusion reactions and a small risk of opportunistic infections. But this main misfortune incident of developing leukoencephalopathy, the drug is hardly approved, otherwise it is found to be efficacious for the IBD. And this was the end of this class. Thank you.